This is the Psychcast by MDedge. I am the voice of MDedge Podcast, Nick Andrews. This is our first ever throwback edition of the Psychcast. We're going to do this once a month, perhaps a little more, perhaps a little less, where we republish and brand and splice up some of our earlier episodes for those of you who haven't had the opportunity to listen to us for all 80-plus episodes. This first In Case You Missed It episode will feature 3 different episodes spliced together into one. It was a big, long interview with Dr. Henry Nasrallah. Of course, it was about schizophrenia. The editor-in-chief of MDedge Psychiatry and the host of the Psychcast by MDedge, Dr. Lorenzo Norris, talked with Dr. Nasrallah about manifestations, etiology, and, of course, how to treat the first episode of psychosis. We hope you enjoy this In Case You Missed It edition of the Psychcast by MDedge. And we'd like to remind you that new episodes of the Psychcast are published on Wednesdays. Like all Psychcasts, of course, we encourage you to get in contact with us if you have any ideas for the show or suggestions about guests. Our email address is podcast@mdedge.com. You can follow us on Twitter at MDedge Psych. That information is available in the podcast notes as well. If you enjoy the Psychcast, please recommend us to a colleague and give us a 5-star rating if you think we're worth 5 stars on Apple Podcasts or iTunes. And, of course, if you write us a review on any podcast platform, we will take it seriously. We read all of those. And we have made changes to the show based on your recommendations. Okay, let's jump right into the editor-in-chief of MDedge Psychiatry, Dr. Lorenzo Norris, and his conversation. That was episodes 1, 2, and 3 of the Psychcast way back in April of 2018. Please welcome Dr. Lorenzo Norris and Dr. Henry Nasrallah.
Dr. Nasrallah, it is truly great to have you on the MDedge Psychcast. Why don't we go ahead and get started with a discussion of what we currently understand about the etiologies of schizophrenia.
Thank you, Dr. Norris, and I'm pleased to speak about schizophrenia and its various aspects and some recent advances in understanding this serious brain syndrome. Let me start out by talking about what is schizophrenia and what is its etiology. The last 30 years has shown us in research that schizophrenia is actually a neurodevelopmental disorder. So essentially, something goes wrong during fetal life when the brain is being basically constructed, and so the connections become different, and some regions may develop more than others, et cetera, et cetera.
Given the complexity of the genetics of schizophrenia, do you feel as though that this inherent complexity in regards to the genetics is what lends itself to the heterogeneity, if you will, of the schizophrenia syndrome and the presentations?
The word heterogeneity is almost synonymous with schizophrenia because of the various ways genetically. We haven't even talked about the environmental yet, which are also hundreds of ways. The heterogeneity in the etiology leads to heterogeneity in the presentation. Even though most patients with schizophrenia have a similar phenotype or clinical presentation, which includes delusions, hallucinations, thought disorder, agitation, catatonia, etc. They have it to different degrees, and some patients have more delusions, some have more hallucinations, some have visual, and some have auditory, and some have somatosensory delusions, hallucinations, etc. And some have good thought, good thinking, straightforward thinking, and some have very bizarre thinking, etc. So yes, the heterogeneity is linked. The clinical heterogeneity can be linked to the genetic heterogeneity. Absolutely.
Are we at the point where we could actually give genetic counseling, or are we still far off from that, in your opinion?
We can do some of that. Genetic counseling, for instance, genetic counseling is relevant for males. We advise males to have their kids before age 40, preferably in their 20s and early 30s, if possible. But in terms of detecting the genes and CNVs and mutations, that can be done, but it's not done routinely because it's still difficult to identify a particular genetic disorder in a particular patient. But it will definitely be more available in the future as many of those genes are identified and we know what they do. Then that can become a ripe area for genetic counseling.
many of us who work with populations seriously mentally ill in the hospital, if you will, severe bipolar disorder, severe schizophrenia, sometimes it may be difficult to go 3 generations back for family history, which I really love that you brought up that point, and that's an incredibly important point. But what occurred to me as you were talking, many of these environmental risk factors, the infection, lack of exposure, or if you will, vitamin D deficiency, sexual or physical abuse, labor complications, these are also additional factors that we can actually screen for as clinicians in the hospital.
Oh, absolutely. Absolutely. And I do that. I always, whenever I'm evaluating a new patient with a first episode psychosis, I go to the mother and ask her 50 questions like, did you have this? Did you have that? Try to remember when you were pregnant with this particular child of yours. I go through a whole bunch of questions just to, as you said, to rule out the possibility that there was a environmental cause during pregnancy.
That is so vitally important. And what I'm hearing you're doing, that one of the things that I've tried to do and even teach future clinicians is that when we suspect schizophrenia, similar to other, if you will, nuanced interviews, we probably need to start incorporating more of a focal interview designed to really elicit some of these, if you will, historical factors that are going to be able to better inform our treatment. I think sometimes due to time constraints, difficulty with having to manage EMR records or things of that nature, at times that can prevent us from going deeply into this history, the history that can help us better diagnose and categorize our patients. One of the take-home points that I take from this is what you started with, Dr. Nasrallah, is that this is a neurodevelopmental disease that has, if you will, genetic, if you will, components involved in the etiology as well as environmental components. And this is something that I think can be very challenging for family members as well as the public in general to understand.
We don't have to get all that information in the first session. Definitely there's a lot to evaluate in the first session, but it can be done in subsequent sessions just to add information and put it in the chart. And also we can create a questionnaire that we can give to the mother.
Next valuable point that you brought up, which I personally don't think we make enough use of in the field of psychiatry, is, if you will, questionnaires and checklists when appropriate. And I think we can make use of these in a way that are compassionate, humanistic, that will not interfere with our ability, if you will, to engage in or establish a connection with our patients. So that is an excellent, excellent practical point.
And the first day of life in the newborn nursery, you would think that, you cannot tell the difference, but actually she noted a difference. And the infants, newborn infants who later become schizophrenic, they were awake an extra hour or so in the first day of life. But then she followed them up for the rest of their growth, and especially the first year, and noted a lot of erratic development. They would achieve a milestone and then lose it, achieve another milestone and lose it. The neurological development was clearly not normal. Later on in the latency years, 6, 7, 8, 9, 10 years of age, interesting studies were done by Dr. Elaine Walker and her colleagues in the 90s, where they obtained movie clips, home video clips from NAMI families whose children are already young adults with schizophrenia. Those kids who later develop schizophrenia compared to their siblings, they tend not to be very playful. They did not, they didn't look bubbly and playing with the ball or the train or whatever. They tended to stay close to mommy and watching their other siblings. Another stage of schizophrenia is the prodrome. Now, the prodrome is roughly defined as the last year or two before the onset of psychosis. Here again, additional changes take place. Those young kids, adolescents, become even more withdrawn, become suspicious, not yet delusional, but more suspicious. They develop negative symptoms. They start having illusions, not hallucinations, but they misinterpret stimuli. We refer to schizophrenia as having stages, just like cancer. In cancer, if you come to the oncologist with stage 1 cancer, the prognosis is very good. You can actually recover and survive cancer. The more you advance, second or third or fourth stage 4 cancer is deadly. I mean, it's basically terminal. And the same thing is happening with schizophrenia, but I don't think many people realize how risky it is to let the patient continue to have relapse after relapse. because their brain is literally being destroyed. To me, psychosis is as dangerous to the brain as a stroke. But people take stroke much more seriously than psychosis.
Yes, absolutely. People absolutely take stroke as well as cancer far more seriously than psychosis. And I thought it's very interesting that you draw that parallel between cancer and schizophrenia and the different stages. Having worked in the field of psycho-oncology, one of the biggest things in regards to cancer is recognition and early treatment before you get to those later stages. And something that you just said that I'm not sure that is in everybody's, if you will, language or common thought process, but just the idea of schizophrenia being a neurodevelopmental disorder that then turns into a neurodegenerative disorder. When we think neurodegeneration, we commonly think Alzheimer's, things of that nature, and that's very cemented in people's heads that we have to conserve brain tissue. Everyone, I would say a large number of people in the lay public understand that. I do not believe that idea is fully embraced with the passion that you've described it with schizophrenia, and that is unfortunate.
It is unfortunate, and I wish people would recognize that, because we can do much more for our patients than what we're doing right now. We're delaying treatment, and that can lead to more brain damage. We also allow patients to relapse again and again. And I say we allow them because it's like benign neglect. We give them pills to take that they don't. They're incapable of taking them. And that causes recurrences of psychosis. And like I said earlier, they cumulatively, the psychotic episodes are part of the duration of untreated psychosis, the DUP I mentioned, which are very negatively prognosticate the future of the patient. So, yes, I would like to re-emphasize what you said, that if only clinicians would take psychosis seriously, and even the law. I mean, I wonder, why do we sometimes delay treatment until a court order comes in, forcing medications on a patient who absolutely refuses treatment because they don't think they're sick, very typical of schizophrenia patients. And the more days of waiting before a court order comes in, the more damage to the brain.
We need to take it far more seriously. And to go back to your earlier thought in regard to maybe why this is the case, and I'm sure other clinicians that work in hospitals or outpatient clinicians who work with those with serious mental illness, whether severe bipolar disorder or schizophrenia, I think one of the bigger issues that you mentioned in the previous podcast, Dr. Nasrallah, has to deal with the idea of stigma. People do not recognize, even though schizophrenia can manifest in a multitude of ways, I think that there is still, even among clinicians, a really good understanding that this is a neurodevelopmental disorder with absolute markers in regards to pathology. Do we have a clear etiology? No, we do not. But we certainly have ample evidence that this is a neurodevelopmental disorder. And as you just illustrated, that this can progress to neurodegeneration. And one of the things that I think about, again, with that idea of psychosis is brain damage. I think if people actually got that in their head, it would make sense. To give our audience an example, those of us in the field of consultative liaison psychiatry or psychosomatic medicine, we are very clearly aware that a psychotic episode or manifestation in the throes of delirium or post-stroke or post-MI, but I'll go stroke and delirium, I have always viewed that psychosis as a marker of underlying brain damage in those situations, no question about it. But if you do not have those conditions, or the same thing could be said for cancer in terms of a tumor metastasizing, but if you do not have those conditions, there can be, from what I can see, a tendency to not view psychosis as, if you will, a marker of something severely going wrong in the brain. If we can really get with the idea of psychosis is brain damage, as you just illustrated, I think it would change our treatment paradigms and how we advocate for our patients significantly.
You're absolutely right, and we need to emphasize that disorders of the mind are disorders of the brain. People look at behavior and words and thoughts as if they are not part of the brain. They are generated by the brain, by brain disease, and we should stop thinking of all psychiatric disorders as disorders of the mind, of the psyche. I mean, this is really old-fashioned, ancient thinking. This is all psychiatric disorders are brain disorders. And we are finding that many of the acute episodes, not just of psychosis, which is probably the worst, but episodes of mania, episodes of depression, acute episodes of anxiety are all associated with neuroinflammation, which I'll talk about in a minute. That means that there's something not good going on in the brain physically during those acute episodes. And in the case of psychosis, it is clearly a neurotoxic process that is destroying the brain and its integrity and progressively. Like I said earlier, like Alzheimer, it's like dementia. Everybody thinks of Alzheimer as the neurodegenerative disorder. Well, so is schizophrenia. And the more you allow it to relapse, the more degenerative it becomes. I mean, we need to change our conceptualization of the illness as a dementing or degenerative process in order to change our clinical habits and clinical practice. That's the whole idea. We are not treating schizophrenia like we should. We are allowing it to deteriorate, without realizing. We should, though, knowing that it's the neurodegenerative. Why on God's earth are we letting our patients decide whether to take pills or not by giving them their pills and sending them home when their life is at stake? Like we said earlier, once you develop schizophrenia at age 20 and you keep getting relapses, you spend the next 50 years of your life totally disabled, just like an Alzheimer patient becomes disabled. I mean, the similarity is appalling, but it's a young person who is doing this at age 20, not at age 80 with Alzheimer's disease. We should really take it much more seriously than we are.
We should take it extremely seriously. And that narrative that you just put forth, I think, is that what occurs. If you think of, if you will, schizophrenia is similar to dementia, but early onset and starting in 20s, and then you've got perhaps 40, 50 years, depending on how we view the lifespan of schizophrenia, of disability, illness, and most importantly, suffering. We definitely have the ability to do more for our patients. And I would also add that, yes, schizophrenia, as you illustrated, can have multiple heterogeneous presentations. But we as clinicians, we actually do have the evidence and the tools, as you alluded to in the first podcast, or not alluded to, you said directly. We can go through a checklist. We can actually do interviews that are far more systematic to help our patients understand what phase we're at, and also make sure that we have additional evidence to back up what we see from the patient's symptom reports and what we see with the signs. If we do all of these things that you outlined through these various podcasts, I think we can come about a faster, clearer diagnosis and really be of more support for our patients in stopping really brain damage. And that's I'm probably actually going to change how I view it, how I teach it, and start referring to it as that untreated psychosis is brain damage. And it's our colleagues in stroke have that down very clearly, and we probably need to adopt that ourselves. Dr. Nasrallah, again, I want to thank you so very much for this incredibly informative discussion during this podcast. To our audience, if you haven't listened to the first podcast where Dr. Nasrallah discusses the etiologies of schizophrenia, I would highly encourage you to do so. Dr. Nasrallah has left us with a plethora of information, and I would almost say, if you will, a mission statement. We need to treat psychosis.
If you wait till the patient has had several brain-damaging psychotic episodes, it's like calling the fire department when your house has completely burned down to ashes. Then you call the fire department? You call them when the first flame appears in the kitchen, and that's the first episode. That fire department is the equivalent of a long-acting injectable. That's when you use long-acting, as early as possible, because that is the best leverage we have against psychosis, against preventing the neurodegeneration.
As I listen to you, Dr. Nasrallah, what I think about is really our goal has to be the first episode is the last episode of psychosis. That's got to be the mission.
Absolutely. They're already labeled as basket cases, and I put them on injectables, and I watch them for the next 5-6 years. And I am very gratified that they do gradually, much slower. It may take 2 to 3 years, but they do get back to their normal self. But it takes much longer than in the first episode. So it's not too late to use injectables after the first episode, but my God, why are we letting them lose so much tissue and have so much suffering, so much PTSD, so much stigma, so much poverty, so much incarceration, that comes from having repetitive psychotic episodes and deteriorating. We can prevent all of that by utilizing, exploiting those agents.
We have to take this seriously. We have to realize psychosis is brain damage, and we have to advocate and treat our patients with what is most effective and gives them the best opportunity to live the life that they really wish to live.
I wrote in Current Psychiatry a few months ago, and in which I advocated that psychiatrists should behave like cardiologists. Absolutely.
Yes.
For the reasons you mentioned. When a patient comes with a first heart attack to a cardiologist, the number one goal for a cardiologist is never, ever, ever, ever let them have another heart attack, because the first one already damaged part of the myocardium forever with the infarction, and they cannot afford another one because it will destroy another part of their heart, and they will either die outright or become so weak they need a heart transplant, which is hard to get. So what they do is they multi-pronged approach. They change their life completely. They change their diet entirely. They also put them into rehabilitation and exercise to strengthen their heart and lung. They make them stop smoking completely. They give them multiple medications to reduce risk factors, like hypoglycemic agents, like statins, like antihypertensive drugs, like beta blockers. I mean, they surround them with this very aggressive approach to protect them from a second heart attack. We in psychiatry must call schizophrenia a brain attack. Exactly. Yes. Like a heart attack, because the first one already damaged part of the brain. We cannot afford to let them have more damage. And the best thing we can do for them, injectable antipsychotic before discharge from that hospitalization, and surround them with good psychosocial support and social skill training and voc rehab and so on. Combining the long-acting with psychosocial intervention is what we must do for every patient with first episode psychosis.
Dr. Nasrallah, I want to thank you so much for this third podcast and a series of podcasts addressing the etiology manifestations of schizophrenia. And I certainly hope that the audience, if they haven't listened to your two previous podcasts or reviewed some of your work, I certainly hope that they do.